Hey everybody, Dr. Mike Mah here. Welcome to Real Mental Health, and I am thrilled to have Dr. Michael Kanell back in studio, and today to pick his brain on first and foremost borderline personality disorder and the overlap with bipolar disorder, why they can be misdiagnosed. So the overlap and also the differences. Welcome, Dr. Michael Kanell, board certified psychiatrist, forensic psychiatrist subspecialty, and an ISTDP specialist.
Also, thanks. I'm happy to be back. It's great to be here, and really interested, really excited about the topic. This happens, the bipolar disorder and people with borderline personality disorder and a few other diagnoses as well. They really do get mixed up all the time, and even in the field, there's been discussion. And this is something I think that's unique to psychiatry. Well, I don't know how unique it, but it's important. It's an important part of psychiatry is that, we're talking about mental health disorders, and these can be very nebulous concepts, and trying to really prove to ourselves and to our patients and to, insurance companies and everyone that these are discrete syndromes that do exist that are treatable has been difficult, I think, over the past 100 years or so. I think we've gotten a lot better at it. But this is one, overlap with borderline seems to happen over and over again.
Yes, discrete syndromes.
Yeah.
So borderline personality disorder, bipolar disorder, a roadmap for everybody watching. We're going to define both, go over the diagnostic criteria of both, a little bit more detail with borderline. We'll talk about the history of borderline personality disorder. Where did that word even come from? We'll talk about popular features like splitting. We will talk about treatments for both where there is overlap. We'll talk about medications like mood stabilizers, like lamotrigine, for instance. Is there evidence for using mood stabilizers in borderline? We'll find out. We'll talk and get your advice for those who have a family member or a friend that has borderline personality disorder and how best to interact with such a person. And then we'll go to the Q&A. So first, tell me, what is borderline personality disorder? I will at some point read the diagnostic criteria. So let's first get into Dr. Kanell. What is borderline personality disorder?
So it first was included in the DSM in the 1980s. And we call it a personality disorder, but there's some thought that it's more of a syndrome at this point. It does seem to have a pretty set and stable course. But if you want to think about it in very simple terms, you want to think about borderline personality disorder as an issue with relationships, both relationships with others and then relationships with yourself. So relationships with others for people who are suffering from borderline, they tend to be pretty chaotic. And there tends to be a lot of emotional outbursts that can really damage the relationships. And then the relationship with the self tends to be pretty unstable as well. So the person doesn't have a clear sense of self. Their identity can seem to shift from context to context. And the person is on some level aware of this and is aware that there's not a really continuous through line. And so they suffer from a lot of, they'll call it dysphoria, which is kind of just feeling bad, or maybe a chronic sense of emptiness. And because of that, and then also because of the difficulties that they have with relationships, there will be a lot of suicide threats or suicide attempts. That's another very common feature of the disorder. I'd say that those are sort of some of the prevailing themes that you see. So just to kind of list them again, you have these emotional outbursts, you have these unstable relationships, and then you have this sort of a sense of emptiness or a poor sense of self. And those are some of the most common things that you'll see.
So trouble relating to others, trouble relating to oneself, and we'll get more into that.
Yeah.
And so they're lacking a solid, stable sense of self, a sense of identity. What is that? How do you even define an identity? How do you define what a sense of self is? I've thought about this a lot. And what it makes me think of is, I saw, there was an expert once, this is sort of a psychoanalytic sort of psychiatrist who said this sort of in an offhanded way, but they said, what people who suffer from borderline and people who suffer from narcissistic personality disorder have in common
is that they have an unstable sense of self. Or I think the word they used was identity diffusion. And I thought that doesn't make sense, because aren't narcissistic people like so confident in themselves, and they have, I'm the best, and this very sort of internal grandiosity. Are they not so clear about that? And so I asked about it and tried to get some clarity on that. And this helped me understand the idea of what is a stable sense of self. So people who are suffering from narcissism, they also likely don't have a good sense of self. And that's because this aura of grandiosity and this aura of like competence and of like, I'm the best, is really just them trying to present something to the world. There's different types of narcissism, but in this sort of type of narcissism that I guess this guy was thinking of, they present to the world a facade of competence and grandiosity and of excellence. And because it's just a facade, the internal sense of self on the inside is actually not there. And so they're not gonna, if the facade ever gets damaged or threatened, then they really have to resort to very extreme defenses to try to hold up the facade, because without the facade there's nothing left. So the thing that would be behind the facade, that's the self. And this is similar to people who suffer from borderline, because they really tend to change very dramatically from context to context. And so in the same way that the narcissistic person will put forward a facade, so too will the borderline, but the qualities of the facades are different.
So the borderline facade. So the narcissistic facade, I'm a narcissist, my core self, there's some sort of like deep-seated emptiness, insecurity, lack of worth. That inner voice, I never actually like assert into the world because I'm so insecure and worried about like not being accepted and totally rejected.
Absolutely.
So I try to live my life as this like grandiose facade, and I do what this guy would do, right? This like grandiose, totally accepted person. And then as that little voice, that who I actually am, what are my values? What do I care about? What do I actually think? Is this funny? Am I going to laugh?
Exactly.
Do I express my like love for this blah, 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 blah?
Right.
As that voice is shut down, and you're just acting a certain way that you feel like is acceptable, then that you kind of never even develop that sense of self.
Exactly. That little inner voice that would be telling you like, I like this, I don't like that, that really cares about what you do want to do and what you're interested in and what's funny to you and what's great to you. Yeah, I would say it atrophies, but you're right. It kind of just never develops. Or maybe, who knows what happened in anyone's childhood, right? But it had a chance to develop and it didn't for some reason.
Exactly.
But the same thing happens with people with borderline personality disorder. But instead of responding to the lack of having their own inner voice that tells them what to do, by putting forward like, well, I can see what is the best, so I'm just going to put the best foot forward. People who are suffering from borderline are more like, they're very in tune on some level with other people's emotions, like almost too attuned, you know? And so they'll be sensing what is it that the other person wants, and then they'll be trying to cater what they put forward to what the other person wants.
Exactly. Also stemming from fear typically, because the fear of abandonment in a borderline is massive. So you say they have this like shifting identity.
Yeah.
What I see in practice is often the identity and this self shifts to mold what they feel like this other person wants, to avoid and to reduce all risk of that person abandoning them or rejecting them.
Absolutely.
Now, let me pause there. Let me go and read the actual DSM-5 diagnostic criteria of borderline personality disorder.
Okay.
And then we're going to go through these features one by one, and I'm going to get your take on them, right?
Sounds good.
So, borderline personality disorder. Patient has a pervasive pattern of instability in interpersonal relationships, self-image, and affects, and marked impulsivity indicated by at least 5 of the following 9 traits. By the way, I'm going to get you to define what affect is later.
Okay.
So, frantic efforts to avoid abandonment, unstable and intense interpersonal relationships, identity disturbance, impulsivity, recurrent suicidal or self-mutilating behavior, affective instability, chronic feelings of emptiness, inappropriate, intense anger or difficulty controlling anger, transient stress-related paranoia, or severe dissociative symptoms. Now, part of a personality disorder is that these features are relatively inflexible and pervasive across multiple contexts. So just because someone is behaving this way in a specific relationship is not diagnostic this person has a personality disorder, right? Dr. Mike, I'm in a relationship with this person. I think he's like totally narcissistic. Does that mean he's a narcissist? Well, is it pervasive across like time and space and other relationships? Is it pervasive?
Contexts, right?
And of course, like anything, these symptoms result in significant distress or functional impairment. Now, a lot of what you said is there. So let's talk historically about where did the word borderline come from? And then what I want to ask you is how does this develop? Because of course it can be born from like emotional, like attachment trauma from major attachment figures. But personality disorders are not always a result of attachment trauma and trauma from like your parents or whoever raised you. It can also develop later on in life. So first, tell us about like where this word borderline comes from. And after that, I want to know maybe a case example of how does one develop borderline personality disorder?
Yeah, we can. Yeah, I'm excited to talk about where it comes from. And what you say is true that, we've seen that people with borderline personality disorder, it is very common that they have had pretty difficult childhoods. At least, there's the adverse of childhood experience sort of questionnaire. And usually there will have been at least one. And I say usually, I think the number is like 70% of people who suffer from borderline.
70% have had an adverse childhood experience, their ACE score. Yes.
Yeah. But that leaves you 30% that didn't, right? So the whole picture can be difficult to really figure out where it comes from. But we do tend to, it's from a theoretical stance, it's easy and sort of cogent to say, well, look, here's a person who, they present the identity that they're anticipating the other person is going to be okay with to keep the other person calm, right? Like that, it makes sense to be like, well, maybe they grew up in a household where that's what they had to do, as they were formulating, how do I live in the world? I have to put forth whatever I need to put forth to keep my parents calm because they're more likely to fly off the handle, you know? Or with people with narcissism, it's easy to think, well, maybe their parents really only ever acknowledged them or rewarded them or paid good attention to them when they, demonstrated excellence or success, So maybe they, and when they did other things, they were dismissed or belittled or something. And so maybe they just learned that they needed to put forth this, narcissistic, grandiose veneer. So it makes sense theoretically, but then it just doesn't always pan out in the.
But let me interrupt you because what you said is hugely important. Yeah. So what Dr. Kanell said is these patterns of behavior of how they relate to somebody else, for instance, their parents, when they were young, this pattern of behavior was rewarded by their parents, right?
In a sense, right?
So what is adaptive as a child, meaning what you have to do to adapt to survive, to please your parents, to make sure that they don't get upset and abandon you, in which case you're dead, right? So what's adaptive as a child to make sure that you don't lose the connection with your parents can become maladaptive as an adult. So here we can look at these patterns of behavior that served you as a child and then take a look at, wow, these are causing significant problems in my life as an adult.
Yeah. Because the structures or patterns or habits that you build in that sort of an environment are probably not going to work very well you'll see these personality disorders get diagnosed, in the late teens and the early 20s. And that makes sense because that's when the person is sort of hatching, right? They're sort of moving, they're progressing away from the family into the world at large. And Erik Erikson said that around that time in life, the real struggle is intimacy versus isolation. Are you able to create new intimate relationships, go out and find a new place for yourself and new partners and new connections? And if you're using an old template that worked for your parents, but has a lot of things that tend to really bother other people, then it's really gonna get you into hot water. hence the relationship instability. And
I love that word template.
yeah,
It's a template of relating to others that's now not serving them.
that's right. Yeah.
Yeah. Hey guys, Dr. Mike Mah here, board certified psychiatrist. Now, there is something wrong with the experience that I hear from a lot of patients when they see their psychiatrist. Psychiatrists are not taking enough time, they're not getting to know patients well enough, and they're not coming up with like a comprehensive plan that patients feel is individual to them, what they're going through, what they're suffering from, and what their goals are. I thankfully have been able to provide this level of holistic, comprehensive care in my self-pay cash business, where we have the luxury of taking the time to do things the right way. It's been a goal of mine to provide this type of care, this high-level, holistic, comprehensive care accessible through insurance. I'm thrilled to announce that I've opened a psychiatric group practice called Century City Psychiatry, where I've hand-selected some of the top mental health professionals who directly under my supervision are offering this level of care, but accessible through insurance. If you or anyone else you know is seeking psychiatric care in the state of California, visit www.centurycitypsychiatry.com. Thank you.
So, but your question was,
History of borderline. So where does that word come from?
Yeah. And I think this is,
and then we'll come back to like, give me like a vignette or a case example of like,
we'll come back.
Something that can give birth to a borderline personality disorder. So where does the word borderline come from?
I love this question because when I was first, exposed to personality disorder, some of them seem to make a lot like narcissistic. Okay. Maybe you've heard the story of Narcissus and that makes sense. Okay. That there's some clarity there. Dependent personality disorder is very clear and evocative, right? Paranoid personality disorder. I don't think it just takes too much cleverness to figure out what that might mean. But borderline what? A line that's a border of something. It's like it's very vague. And what's interesting is there have been proposed ideas, and some people are in favor of this, of changing the name of borderline personality disorder to something like dysregulated emotion disorder, or like affective, I think, instability or something, personality disorder. And it depends on the patient, but when I put myself in the patient's shoes, I think I would kind of prefer having the name be a little bit more of a mystery, because then if I need to tell someone about it, then when I say, oh, well, yeah, it's because I'm suffering from borderline personality disorder, likely the person's not going to be able to just intuit what that means. And so then now I get to describe it for them and sort of create the idea of it in their mind, rather than if I tell the person, oh, yeah, well, I suffer from like dysregulated emotion disorder. I mean, that sounds pretty rough, I think. And I don't know, it feels like it might be harder to get support with something like that.
Yeah, that's a great point.
So I kind of, and even though the name comes from an old history, and I'm going to talk about it in a second, I kind of think it's good, because it is a very disturbing disorder, and people do have a lot of major disturbances in their life, and to give them any sort of ability to control the presentation when they're presenting it to people and trying to get better, I think that's a nice thing to offer them. But borderline. So this word comes from an old psychoanalytic idea. Back before the DSM per se, and like back when psychiatry was still trying to sort of formalize diagnoses, they would sort of group the ways that people would suffer into two major camps. There's the people who were healthy and didn't seek treatment, right? But then there were two major camps of suffering. One of the types of suffering was neurotic suffering, and the other type of suffering was psychotic type suffering. So, and the prevailing, this sort of the big difference between those two is that people who were suffering in a psychotic manner seemed to be pretty more disconnected from reality. Like you couldn't really like check with them on the reality of a situation and be confident that they were going to give you an accurate assessment of what had actually happened. But people who are neurotic are usually able to, they call it reality testing. They can reality test better. So if something's going wrong, you can be like, well, so what is it that actually happened? And they can give you a fairly accurate description of the actual like things that have transpired. So those were the two groups. And there seemed to be a third group of patients that came somewhere in the middle, where most of the time, if you check with them when things are happening, they'll give you a fairly accurate description. But when the heat really gets turned up, or when they have a pretty serious trigger, or there's some sort of major relationship disturbance, you'll see that they tend to start having perceptions of reality that don't really pan out. They seem to sort of step into that psychotic area where they're not really understanding the truth of what seems to have actually happened. And so it's very hard to deal with because, they're not, it's not an accurate assessment of the situation. And so that's where borderline came from. It was people who they seemed to be less well reality tested than the neurotics, but a little bit better than the psychotics.
So you're on the borderline between neurotic and psychotic as far as this like psychic suffering and how you're presenting.
Now, so there's a famous psychoanalyst and psychiatrist named Otto Kernberg, and he was the one who sort of defined the borderline personality disorder, or the borderline personality organization. And he kind of identified three different facets of it. You can imagine this is a sort of spectrum. We already talked about reality testing. The other thing that you'll see in addition to reality testing is the types of defenses that they use. Now, defenses is a behavior or a thought or something that you do to try to deal with a disturbing feeling, a disturbing memory. If something happens or something comes up that really bothers you, how do you get through that? How do you deal with it? Like if someone, for example, cuts you off in traffic and then you get angry and you're not happy being angry, how do you deal with that? If you're a depressive, neurotic person, you're pretty likely to say like, oh, I'm the problem. I should have been paying more attention. If I had been paying more attention, I could have dealt with the situation and prevented the situation better, right? But if you're more like a paranoid kind of psychotic kind of person, you might get angry at the person, not notice that you're angry, and immediately believe that the other person cut you off on purpose because they were trying to spite you.
How does that defend you against a distressful
feeling? So then now you're not the one who has to be angry, right? Now you get to have the moral righteousness of being like, this guy, he's just being a jerk. He's actively coming out to give me, maybe I should follow him down and let him know give him a piece of my mind. But either way, it gives you something to do rather than just to sit there and be angry yourself.
So here, Dr. Kanell is talking about defenses.
Yeah.
Can we say ego defenses? Is that a synonymous term?
Yeah.
So defenses. Defenses are ways we consciously or unconsciously defend against pain, distress, whether it's something painful and distressful coming from inside of you or from outside of you with somebody else or the world.
Yeah.
So what are the major defenses that Otto Kernberg recognized in the borderline patient?
So the number one thing that I think he recognized, and everyone sort of agrees with this, and it's in the diagnostic criteria here that you just read. It is right there in the diagnostic criteria, is splitting. So splitting,
hugely important. Yeah. So what is that?
The idea was originally sort of developed by Melanie Klein, but it's really been expanded over the years. The idea is that you can't see, is that when there's a negative feeling or a negative experience comes up, you have a lot of difficulty holding it together with the positive, and so you have to cut it off. You have to keep them separate.
Okay. Explain that. So if you see something, so say that again, because that's going to confuse a lot of people.
Yeah. So if you
so splitting as a defense. Is splitting a defense? It's
splitting as a defense. Okay. So imagine that you grow up and you're in a religious community, and everybody in the community is they're all part of the religion, and everybody says that the religion teaches good things and it's really great, and you should definitely always believe the religion, right? But now imagine that you see one of the doctrines being taught, and you can see that it hurts somebody, and maybe it hurts you, for example, and you don't like that, right? Well, if there's something being taught that hurts you, and you are in a situation where you can't accept that the religion can be both good and bad, right? Because the religion is all good in your community, then something has to be bad. And you can't, if it's not allowed, if it's not permitted, or if it's not possible for it to be a complex thing that has good and bad facets, then you have to split off the bad part so that this thing can continue to be good, right? So pretty commonly in religious communities, what will happen is the thing that becomes bad is the me, right? I'm bad. I'm the sinner. I failed in some way, right? And the religion is still good, right? This can happen with parents as well, and this can happen with self. You know, it's like who's the good and who's the bad. So you can tell the splitting is happening when in moments of conflict, if the descriptions and the words that the person or the patient is using tend to be pretty exclusively like, you know, just like they're exclusively good or bad. Like, hey, they're such a jerk and they're terrible and they're bad and they always do this to me. You know, this is painting them as all bad, right? And then in that sense, you know, and I didn't do anything to them. I'm out here trying to sacrifice myself to make, you know, their life easier. And what do? Then they come out here maliciously. Now I'm sort of all good, and then the other person is all bad.
Well, let me pause you. Why does the borderline have difficulty comprehending that one entity, one person can have both good parts and bad parts? That a good person might do a bad thing. Like, why can't they comprehend that? Why do they have to split?
I think it's a real,
this is a foreshadowing dialectical behavior therapy, which we'll discuss further in the episode. But why can't borderlines tolerate or comprehend, like, and why do they have to defend this with splitting?
I think it's sort of Emily Klein thought that Melanie Klein, thought that it was a developmental stage that you would move through. You would start out in a stage where splitting makes the most sense, you know, as a child or as a baby. And then the goal or the process is that, you know, as you grow up, you're able to move more frequently into the stage where you can imagine people as a whole and complex person. So there is a process to doing that. The thought that she presented was that it's easier for the child, or safer maybe is the right word, for the child.
Safer,
yeah. Because, you know, Klein's big thing was the good breast, the bad breast. And so the idea there was that the infant who doesn't have any complexity of mind, right? The infant who can't even identify like a table and separate it from the ground, you know, doesn't have the idea of a table in their mind. They have nothing, right? All they know is that when they're in distress, everything is bad. And then when the distress goes away, everything is good. And so Klein's thought was that, you know, the good breast is the mother that shows up and provides the milk, and the baby is soothed and everything is good in the world. And then later on, the bad breast is the mother that doesn't show up and the baby's hungry, and hunger is a painful experience, or maybe something else is happening and it's a painful experience. And so it's better on some level, or safer, to know that you've got a mom or a dad or someone who is good, who cares about you, who is going to be there for you, who is going to, you know, who really is going to make your life continue to exist and keep you safe. And when they do bad things, it's safer or easier to say, well, they did the bad thing because I screwed up, right? I'm the bad one. And now I know that I still have the confidence that outside of my failure, I have a parent that I can rely on.
Wow. Well, there's so much here, right? So let me just stop you and pick at some of this, right? So first of all, it might be safer. Well, before that, perhaps they're stuck in some sort of immature phase of development, because you mentioned infants are doing this, right?
Yeah, that's what I thought.
So perhaps there's like a developmental problem. Second, you mentioned we might split because it might be safer. So if there's some sort of like fear of having pain be inflicted by another person, then maybe accepting someone into your life that has good and bad parts in them might be more of a risk.
Well, it'd be a huge risk, right? Because how can you predict, right?
So it is a defense. It's born out of fear. It's keeping myself safe. I don't want anyone in my life that could potentially harm me. And then the last thing you said is the I'm bad, right? So my parents did something to me that caused me pain. It must be that I'm bad.
Right. I messed up.
I messed up. That might also help give them more of a sense of control.
Yeah,
that
absolutely.
maybe if I adjust my behavior, then this sort of like pain won't be revisited upon me by my parents.
Hence the
They're
identity.
all good. I have more control. It was me that was wrong and bad, because the reality that I can be all good and I'm doing my best and my parents can still cause me pain, that is a very difficult reality to accept. Better I'm bad, it was my fault, I'm actually in control, and if I adjust course, I won't be put into pain again.
Yeah. No, and then that makes a lot of sense, that now you're going to start building this sort of identity that you're going to present to the world that's not the true voice that you've got inside, because you need to figure out, well, what do I need to do to keep my parents good?
It's
right?
fascinating. Yeah. So it's like, what do I need to do to keep, how do I warp myself? Because if anything bad happens to me, it's because it's something wrong with me.
I could have prevented it.
So let me warp myself to match this individual, because borderlines are also incredibly emotionally sensitive and picking up on other people's feelings.
Yeah.
Too sensitive, false positives all over the place. How do I warp myself so they don't hurt me? Because if they hurt me, it's only my fault, or it's completely their fault and they're evil, right? They split the other way.
They can, absolutely. And you'll see that actually a lot with people who are trying to work through their childhoods as like a 20 and 30-year-old. You know, they'll be looking back and like, well, my parents, I mean, obviously their parents, you know, most parents do things that hurt their children sometimes, and that's horrible. And most parents don't want to do that. Some parents are much worse than others, right? But you see a lot of, it's very easy to just flip it and go the other way and be like, you know what, I was just a kid and they're terrible parents, you know?
Yeah.
So when you're a kid, then they have to be all good so that you're safe. But if you can get into your 20s and you're sort of kind of self-sufficient, now you can be like, they're terrible and they're all bad. And now I'm just a good kid, you know? Why would they have done that to me, you know? So but a lot of the treatments, and I imagine we'll get into this, a lot of the treatments, the goal is to try to talk through these moments as they come up in people's lives and try to get them to a sense of middle, you know?
Yeah. And it's fascinating. Now, okay, so we're talking about splitting.
Yeah.
We can come back to this, but I want to make sure we cover the other defenses, right? Anything else on splitting before we move to the other defenses that Kernberg identified in the borderline patient?
No, I think we've got the basics of it. Is there what else do you want to say about it? I guess, here's something that I think is important. And this is, in general, this is true. We're talking about behaviors that people who are borderline do. And it tends to be like people who are borderline, who have a borderline organization, they really do suffer. And the relationships in their close sphere also suffer quite a bit. And it's very disturbing because of how you know, the departures from reality, it can have really, really bad fights. So it's easy for especially people in their lives to be like, oh, they're just malicious, or they're just, you know, trying to get something from me, you know, or they're you know, all of this is like motivated. And while it is motivated in some sense, I think it is motivated by a desire for safety and a constant sense that they can't have that as well. So it's a tension between those two. And what I wanted to say about splitting is it's very unconscious. You know,
Yes.
this is not something that people do purposely. In fact, I don't even know that you could actually truly split in a conscious and purposeful way. I had an experience. Yeah, we all use different defenses, and it's not, if you split once, now you're borderline, right? It's like it's how often do you use it and how
It's a pervasive
reliable, pervasive pattern, right? And it comes up in multiple different contexts, right? Your boss at work, your relationship at home, your brother, you know, your friends, right? Everywhere. So, but I had a moment when it was with my girlfriend at the time, where I was talking about something that happened in my life earlier with sort of some foundational, I don't know how much detail I want to give here, but the short of it is that, like, at the end of a very difficult discussion that I had with my girlfriend, it became clear to me that I had thought that she was having all of these feelings about this facet in my childhood. And it turns out that no, those weren't her feelings at all, because she grew up in a totally different situation than me. And she didn't have any strong feelings about this stuff that I was describing at all, because it wasn't like terribly bad. But I had super strong feelings about it because it was personal to me in my childhood. And I didn't realize that at the time. And so really, like the only conclusion to draw is that I had these strong feelings and I had split them off and then imagined that they were coming from my girlfriend. And I cannot overemphasize how real it felt to me that like I could tell that she definitely was having this like anger about the thing that had happened. And she was dismissive about it. And none of that actually met with the reality. So like when I talk about what it is to have an unconscious thing happen, it really is totally outside of your awareness.
How is that different than projection?
Well, it's a combination. This is the other thing that you'll see with people who are borderline. And so this was me using a borderline defense at that time, you know. But it's you split off the bad, right, or the good, and then you imagine it coming from the other person. That's projection. So these two defenses seem to go hand in hand for people who are suffering from borderline personality disorder.
Yeah, fascinating.
So projection is when you I don't want to say imagine because it makes it seem like you're doing it on purpose, but because it really is just it's an unconscious experience that it is coming from the other side. But projection is the idea, the sense that you have that a feeling is coming at you from someone else. You know, one of the ways that it was explained to me when I was in my psychoanalytic psychotherapy training is, you know, when you go to like a graveyard, it can feel like it's a really scary place and it feels very spooky. But like in objective reality, it's just a patch of land, right? And so all that feeling that you feel in the graveyard comes from inside of you. But if you ever have felt like spooked out, it's like it came from inside of you, but you projected it outward.
Onto the piece of land with the...
Exactly. Yeah. And you really feel it coming from the outside. Also works if you've like ever watched a scary movie, like when you're like home and like alone or just a few people in the house at night. And now that same place where you're living, your same apartment, your same house, you've been fine there forever. But that night, for some reason, it just feels very unsafe.
Yeah.
You know? So it's like, that's projection. You're projecting the feeling out there. And then you really feel like it's outside of you.
Yeah.
Right? Like the danger is outside of you.
Fascinating.
Yeah. So but people who are borderline, they do this all the time in their relationships. And that can really destroy relationships if the other person, you know, wasn't really feeling that, but you're sure that they were feeling like if the other person was not really angry at you and you're sure that they were angry at you and that they were trying to hurt you because they were angry and you come at them like, why did you do that? Why did you hurt me? And you really escalate, then the other person, what are they going to do? They'll be like, what's going on? I didn't know, not at all. And that's how relationships fall apart. Right. And so the fact that when people who have borderline do feel distressed, that's what they do. That's one of the ways that relationships really just get destroyed.
And for the kind of the nerds out there that are really into this stuff, what is projective identification? How is that one level kind of beyond projection?
Yeah. So projective identification is sort of like the next step. From my training, it didn't originally mean this, but it's grown to mean what I'm about to say over the past 50 years. And this is how basically everybody uses it now. Projective identification is when when you have like a feeling inside and then you imagine, I say imagine, right? But it's unconscious. So you're not doing it, but you are, right? You don't know that you're doing it. You imagine that it's coming from the other person. And then you treat the other person in such a way that it ends up provoking the feeling in them. And anger is the easiest one to describe here, right? Because it's pretty straightforward to provoke with people just by disagreeing with them, you know? And so if you imagine that your partner is angry at you and that they're out here, you know, they're closing the cabinets and they're slamming them, you know, and it's like so much louder than it normally would be. And you can tell that that's a sign that they're angry. Then you come at them and you're like, why are you closing the cabinets so loud, huh? You know, and they're like, I wasn't closing the cabinets loud. I'm like, yeah, they're much louder. You're clearly, you know, you can really sort of escalate the situation.
Yeah.
So projective identification is when you elicit the feeling from the other person, even if they weren't having it at first.
Absolutely.
Anger, fear.
Yeah.
Usually difficult feelings.
Not only do you predict that they're feeling this sort of way, you project it so hard that you actually have that feeling arise in the other person. You actually make them feel that way.
Yeah, there's a guy named, there's this Now, his name's Paul Wachtel, and he wrote a book called Cyclical Psychodynamics. And the idea that he presents is that like a lot of these sort of defenses that we use them and they become part of a cycle in our life where they sort of continue, like they feed themselves. And it's not just us, but like the people in our lives we use defenses in such a way that it sort of provokes the other people in our life to do something to reinforce the defense. So here's the person with borderline who's had a number of relationships that have failed, right? And now they're in a relationship and let's say that it's going pretty well, right? But like they're worried that it's going to fail, and then you know something happens and it bothers them on some level, but they don't want it to bother them because they need the relationship to work because it's finally working, right? So they don't notice that it bothers them, but the feeling is still there and it gets projected out, and then they can tell that their partner is mad at them, and then they do things in response to the anger that end up provoking more anger out of the partner, and the partner's like, why am I getting angry? You know, where did this fight even come from? You know, and they don't know. But then they do get angry because they don't know what's happening. And so then they behave in sort of, you know, they act out their anger or whatever. And then it continues, the cycle feeds, and eventually the relationship explodes. And now our person with borderline is, you know, through some way that is truly unconscious, then they're like, what happened? And now my partner's left me.
Well,
they've
manifested their fear of being abandoned. And that partner, God bless them if they're even mindful enough to question where that feeling's arising from.
Yeah.
Now.
Yeah. If they're even mindful, because when you get mad
they'll go automatic.
Nah, you might just go automatic because that's when the feeling's strong enough, you might just do it.
Yeah. For everyone that's made it this far, we're going to give Dr. Kanell maybe 5 more minutes. We'll talk about some other features of borderline that we've got into already. Then we're going to give a quick definition as to what is bipolar disorder. For those that are more interested, you can watch my prior video on bipolar versus ADHD, where we go much more in depth on bipolar. Then we're going to compare episodes of emotional dysregulation that you find in borderline personality disorder versus mood episodes that you find in bipolar, which is one of our jobs, right?
Yeah.
Patients come, they have diagnosed bipolar and borderline. And how do we kind of take the time to sift through what is what diagnostically? So give us a few more minutes on features of borderline, and then we'll get into bipolar and then compare and contrast.
And it really does take, I think that's one of the key things, is that it does take time. Like if someone comes into you and they're in like their early 20s and, you know, they're struggling between, you know, or there's sort of relationship difficulties and there's episodes of depression and episodes of like higher mood, and there's not been any psychiatric hospitalizations. This sort of person, it's easy to be right in the middle of like, gosh, what sort of a diagnosis is it? And so it will take time to do a really good history. And then it might even take a few visits, you know, and you might need to see people over time to really be sure.
Yeah.
So but it is an important thing to make, because we have excellent treatment, really, that can be very helpful for both people who are suffering from borderline and for people who are suffering from bipolar. But the treatments are dramatically different, you know, and the medications that work for people who have bipolar disorder, they tend to be much less effective for people with borderline. So it's important to try to get it right. You know?
Absolutely.
But I guess even if you get it wrong, as long as people are still alive, which hopefully everyone stays alive, then you can try again later.
Yeah.
But so I had a couple of other thoughts that I wanted to say about borderline. These are some facets that don't come, they're not in the classic criteria, but some of the more current researchers have come up with some very interesting ideas. One of these ideas is this idea of the way that people with borderline personality sort of tend to communicate. And one way they tend to communicate is with this idea called double binding communication.
Double binding communication. What is that?
So double binding communication is where you give at the same time or in very close proximity 2 different communications that are like mutually exclusive. Like you can't comply with both of them. And so it's a lose-lose scenario for the listener.
Could you give us an example?
Yeah.
Double binding situation.
Well, so the classic double bind is the be spontaneous double bind, right? Like if you want someone to be spontaneous and you tell them be spontaneous, then you've already failed, right? because when someone tries to be spontaneous, they can't spontaneously be spontaneous because
Fascinating.
spontaneity is defined as not being provoked, right? So like that's the basic idea of double bind. And this can happen. You've probably seen this, I think, in like rom-coms and stuff, where there's like, oh, the girl wants the guy to like buy her flowers for something someday or something. And then the guy didn't buy the flowers. And then she tells him, oh, you need to buy me flowers spontaneously. And then even if he buys the flowers, it doesn't matter now, right? Because he didn't do it spontaneously. So the flowers doesn't matter, right? So that's the sort of thing where it's like, people who are suffering from borderline will tend to do a lot of these tests for their partners in relationships.
A lot of tests.
Yeah. And so they'll sort of imagine like, okay, how can I know that I'm safe in this relationship? How can I know that my partner truly loves me is probably the word that they'll use, because they'll think that if they truly love him or if the partner truly loves them, then that's the thing that will keep them safe in relationships. I don't think that it is the thing that will keep them safe in relationships, but that's what they think. And so they imagine, well, if he does, then he will do this particular thing for me. And then if he does, it, great. That lasts, they'll be happy for a day. They'll go into like one of their high states and be happy for a day, but then eventually they'll need another test, right? But if he doesn't, then, everything falls apart because now they get into a fight. They tell the guy to do it. But then if the guy does it next time, now it's because they told him to do it. So it's still a loss anyway.
How much of the borderline organization and defenses spring from a core fear of being abandoned?
Yeah, it's actually, and so this is the second thing I wanted to bring up. It springs from a core fear of being abandoned and also a core fear of being, they call it engulfment or enmeshed or like overwhelmed, but it's really just a fear of intimacy because there's this core fear also that if they were to get to know the real me, then they would run away, right? And then they would leave. And so, and also it is just legitimately scary if you've lived your whole life, not being able to be your own spontaneous, speak from your heart self, and you've always been living with this facade, then to have someone get close to the actual thing is terrifying because you've never let anyone do that.
It's fascinating. The core fear of being abandoned, which completely dovetails and overlaps with the core fear of not being worthy of secure attachment.
Yeah.
And that there's something wrong with me. And that, again, this person, if they actually get to know me, will not want to securely attach to me and will inevitably abandon me.
Yeah.
Which is also, correct me if I'm wrong, but kind of this like core driver, this fear, I'm unlovable, they won't attach to me, they're going to abandon me, that you find in narcissism as well. Is this the core fear that you find in all cluster B personality disorders?
It's actually pretty common in people who are histrionic as well. But I don't think anybody would say
not
antisocial, sociopathic personality.
But certainly the narcissist the borderline
and probably the histrionic
the defenses in the organization, a lot of it, maybe all, you tell me, spring from this fear of abandonment and not being worthy of secure attachment.
There's this fear. It's a real fear both of abandonment and a fear of intimacy. And so there's no way to really thread that needle. You can't have a behavior that will help you to have a relationship with neither abandonment nor intimacy because a relationship demands one of those two. Either you'll become intimate, or you'll be abandoned on some level. And if they don't abandon you physically, emotionally, you'll be abandoned.
What is negative urgency?
I've not heard of this one.
The inability to tolerate distress and the urgency to engage behaviorally in attempts to relieve this distress.
Yeah. Yeah.
For instance, this borderline patient, they're dating somebody. I've now texted him. Why hasn't he responded in 3 hours? Right? Oh my God, he must be abandoning me. He must be breaking up with me. He must be ghosting me. Oh my God, I'm so anxious. I cannot tolerate this. I have all of this flood of negative emotions. Because of my inability to tolerate distress, I then act with urgency and on impulse, and I show up at his doorstep to try to resolve the conflict because surely he must hate me. And again, it's the distress intolerance and the negative urgency that we often see, coupled with impulsivity in the bipolar patient.
And you give this example, and I feel like that's an example that I think a lot of people, it will match with them intuitively on some level, even if you don't qualify for a diagnosis of borderline personality disorder at some point in your life. I think that a lot of what happens is during these teenage years, you're leaving your family, you're trying to go learn to see if you can build intimacy with another person, and it's tough to do. You might not just naturally know how to do it, and there's like scary moments because you probably will get rejected, and then it's a difficult time. I think what's different about people who are suffering from borderline is that the stress of these teenage years doesn't seem to go away for them, and in fact things seem to get worse as time goes on, and the relationships continue to fail. I think that's probably why does this happen? We've already talked about some of the defenses that they use and how that can get in the way. But there's some studies that indicate that people are just born with different sensitivities to emotions and different sensitivities to distress. There's babies that they grow up and like they can be poked and prodded and they're fine. They can when you expose them to new experiences, it doesn't bother them that much. They're fine.
Mm-hmm.
But then there's babies that are born and like if you introduce a new thing, they freak out and then they can calm down and they're like, okay, I got used to the new thing. But then there's a portion of babies that are born and it's just hard.
Absolutely.
They can't handle new experiences. They don't have regular sleep-wake schedules. They just have a hard time. And there was a study actually where they followed they follow babies from this very young age in these different categories. And they saw that you do have more behavioral problems later in life if you are born with just a more difficult temperament. And now imagine that in a situation where parents are stretched thin, maybe they're working, maybe they have financial distress, or maybe they don't have good emotional coping skills themselves. Maybe they themselves have borderline personality disorder. And now they have the demands placed on them, very, very demanding infant just by their nature, so you're going to have a self-fulfilling cycle where things are going to get worse and worse. And then by the time they reach their 20s, these people are going to have a really hard time relating to people.
Borderline personality disorder, what is the prognosis? Will these patients ever get better, even if they don't seek treatment? Let me start with a meta-analysis and some facts, right? So there was a meta-analysis by the Borderline Personality Disorders, like it was a review. And the meta-analyses of 837 patients across 11 different studies. So they pooled together these studies. These patients were followed for at least 5 years and reported remission rates between 50 and 70% with a mean remission rate, and you can tell people what remission means, of 60%. So it's important to distinguish between symptomatic remission, no longer meeting diagnostic criteria, and a full recovery. So do patients with borderline personality disorders get better over time? Do they get better whether or not they have treatment? And what is the prognosis for someone that has borderline personality disorder?
So if you are going to get better over time, there must be change. But the good thing for people with borderline personality disorder is that there's a lot of pressure to change because, a lot of things are going to be going bad in their lives, especially with regard to relationships. So I imagine that argument might not be the reason, right? But studies have shown that like if you read in the DSM, they'll say like the symptoms of borderline are most present during the middle years of life, like, starting from the teens and 20s and then going up until like the 40s. And then it mentions that you tend to see people have fewer. Is that because they're just older and tireder? Or is it because they figured out how to have a relationship? Or is it because they just got lucky and happened to get into a relationship with one person who was like, calm enough and like had enough wherewithal to like call them on whatever things they were on their double-blind communications and then help them to see it. This is, the book I mentioned earlier called Cyclical Psychodynamics says it says this. It says, look, people will recruit other people into their cycles, their patterns, and then other people will lean into it. But if you happen to try to recruit someone into your cycle and then they don't come into it, you have a chance for change. right? So you have a chance for actually, even without a therapist, but for the person that you're in a relationship with to try to be helpful to working through these things. Now that's obviously not, no one has a responsibility to do that, but if you happen to have that and they're willing to, then that could be a really great thing. And maybe that's one of the reasons that, as time goes on, eventually, some people find good relationships. Otherwise, maybe it's also, it could be a bad thing. Maybe time goes on and they sort of fade away from treatment and they just kind of stay to themselves and are mostly isolated. I don't know, but the studies I've always been taught, and the studies have always said that you see less borderline as age goes up.
Yeah, absolutely.
Yeah.
Now, let's get into bipolar disorder.
Mm-hmm.
I'll ask you your definition. I'll then give the DSM definition. Mm-hmm. And then let's compare and contrast what I said before as far as episodes of emotional dysregulation and borderline. What might trigger those? What does that look like? And then what does a mood episode in bipolar look like? So what is bipolar disorder?
So bipolar disorder is characterized by mania, but bipolar disorder is thought of as a spectrum. And so there's different degrees of it. But the easiest way to know what bipolar disorder is to see a true manic episode. And I feel like if you didn't have a family member who had a true manic episode and you haven't worked in a psychiatric emergency room, quite specifically, I think the likelihood that you've run into a true manic episode is pretty rare. It's tough to just to see it, but it is truly disabling. One of the sort of truisms that people say, and this isn't like data, right? But it's sort of just a thing that people said around me in training is that a true manic episode will end only in one of three places, either jail or a hospital or death, because it is that serious.
Absolutely.
Like a true manic episode is, it's not hard to distinguish from borderline personality disorder. It is very clearly a huge difference.
What does a manic episode look like?
So a manic episode is a period of time where a person's mood is elevated. We say it's the opposite of depression, but that doesn't capture the magnitude of problems that having a truly good mood can feel in your life. Imagine like you're like, in Harry Potter, I think it's the 6th book maybe, where he drinks this potion that makes him feel totally lucky. Mm-hmm. And like he just goes through and everything he does just works out perfectly.
Yep.
Like imagine that you thought that you had drunk that potion, but you had not. And then you felt like you were the luckiest person in the world, but you were not. And so you're walking around just doing whatever flight catches your fancy or whatever you think seems like a great idea, and you're 130% confident it can't go badly, and you didn't actually drink a magic potion, so things fall apart around you.
Absolutely.
Yeah. People are dropping, they'll drop out of college and say they have some really great business idea. And then they'll go, if they can, they'll take out some sort of huge loan and then buy a bunch of stuff. And then it's like a really half-formed idea because they're too scattered. They feel so good with so many great ideas, that they're too scattered to do anything well. And so mostly everything just falls apart, and then now they've got all this financial distress and they're not in college anymore, and then they don't have, their whole future is totally derailed. Maybe they'll break up with their partner and then go have a bunch of sex with people that they don't have a relationship with, and maybe that will cause distress for them. Like it's a lot of just nothing can go wrong. Do whatever you want in any given moment, and it really destroys people's lives.
Absolutely. And if you've seen a manic episode,
Mm-hmm.
you then actually become a believer that mental illness exists.
Absolutely. Yeah. It's so impressive.
It's in your face.
Yeah.
I know our producer, a little personal note, me and my best friend, actually our producer, we had a friend who is bipolar.
Yeah.
And I recall that when he had his first legitimate manic episode, my best friend and the rest of our friends were like, "Oh, okay, so this is severe mental illness actually exists.
This is a real thing.
This is in your face. It's unmistakable. Okay,
you're not just going to go talk about it.
Exactly.
Like you can't figure this out.
No, and then you also start to believe in psychiatric medications." And how there's actually significant mental illness out there that needs to be handled by trained medical professionals that specialize in mental illness. Now, let me read the DSM criteria. So, what is a bipolar disorder? So, for bipolar disorder, bipolar 1 disorder with a true manic episode, the diagnosis requires at least one manic episode, which may be preceded or followed by hypomania or a major depressive episode. A manic episode is defined as a period of abnormally and persistently elevated, expansive, or irritable mood and increased activity or energy lasting at least 1 week, which is very important, or any duration of hospitalization is required, and accompanied by at least 3 additional symptoms, or 4 if the mood is only irritable. Inflated self-esteem, grandiosity, decreased need for sleep, pressured speech, racing thoughts, distractibility, increased goal-directed activity or risky behavior, and this causes significant impairment or hospitalization. So that is what a true bipolar 1 looks like. That's what a true manic episode looks like. There's bipolar 2 where you don't have as severe elevations. And then there's cyclothymia, which is low-grade depression, low-grade kind of mania, and cycling between the two.
Yeah.
So can you tell us, so a lot of patients come in and they think they're bipolar because this word gets thrown around all the time.
Yeah.
But they're actually having like a borderline personality episode of emotional dysregulation.
Yeah.
So what's the difference between that? Because if a borderline gets totally activated, usually interpersonally, they get incredibly anxious. They're not sleeping because they can't sleep. Their mind is racing, but not necessarily, not in some sort of grandiose racing thoughts way, like I'm going to do this, that, and the other that's like goal-oriented. It's usually quite negative, quite anxious, and has to do with the often an interpersonal conflict. They're incredibly emotional, so their mood is high intensity, typically very elevated.
Yeah.
Or it could be the opposite. Things are happening to go right and they're so thrilled and, oh my God, this person likes me. And they're completely like manically euphoric.
Right. They'll feel so good.
They're
when things are
talking a
going
mile
well.
a minute. They have all this energy. They're not sleeping. They have these racing thoughts. They're talking a mile a minute. They have an intensity of mood. So often this can be confused with the bipolar mania, right?
Yeah.
So how do you sift through the difference to make an accurate diagnosis between borderline episode of an emotional dysregulated episode versus a bipolar mood episode?
So one of the first things that, because I was looking into this in preparation for this to really know, one of the things that's most commonly shown in the research is that people will have family histories they will more likely have family histories that support one or the other diagnoses. You're more likely to get the personality disorders in a given family, that it's more likely to be a personality disorder behavior. And then in a family where there's a person who has borderline or bipolar, you're more likely to have another person in the family with either schizophrenia or bipolar disorder or some sort of a mood episode. This can be tough. In the research, this is great because you get really good, very thorough diagnostic information. But when you're working in a clinic, it can be tough to really get that information because people will be telling you what they know, and not everybody knows what bipolar means other than that on the face of it, it sounds like there's swinging between side to side. So diagnosis can be really difficult because people might tell you, yeah, my mom was definitely bipolar, but maybe your mom really just had a borderline personality organization, and you also might be confused by this. And that's what's funny is it's not just patients, but it's also the entire field of psychiatry and psychology that has really struggled with trying to differentiate. There was actually in like the 90s, the 90s and the 2000s, there was a push inside the field to try to sort of bring borderline personality disorder inside the umbrella of bipolar disorder.
Oh, really?
And so there was this thought that like maybe borderline personality disorder really is just like a bipolar type 4, or like a variation of cyclothymia, by which they called bipolar 3 at the time, and so there were people who were writing articles and they were giving case reports and they were sort of making their arguments. And then when I did the research, I found an article by John Gunderson, who was one of the original people who really sort of helped distinguish the syndrome of borderline personality disorder. He wrote a really convincing paper in 2007, pulling together all the evidence and saying, look, these are distinct symptom clusters, and they respond differently to different treatments, and they have different family histories, and there's different genetics, and it's all different. And so these really are two separate things.
Completely separate.
It's a mistake to try to lump these in together. But I think borderline personality disorder causes so much distress in people's lives that they really, and it really would be nice if you could just prescribe a medication and then not have, the affective dysregulation that's common there, or the emotional dysregulation.
So when you're trying to gather a history and look at mood episodes of this patient that presents to you, what do you notice, or what do you try to hone in on as far as the questions to characterize these episodes, to differentiate between, are these episodes of like being dysregulated that you find in borderline, or are these mood episodes that you find in bipolar?
So what I would start with is we call it chronology, right? And onset. So the first question really is like, how did it start? You want to pick a specific episode, and then let's figure out what was going on. How did it start? Because when it's an episode that happened in someone who has a borderline personality organization, there very frequently will be an interpersonal trigger of some sort. The boyfriend said something, or the girlfriend said something, or maybe they actually did break up, maybe they lost the relationship, or maybe something happened at work, but it will be pretty trivial to find some sort of a stressor in their life that really bears a lot of emotional significance. Now, they might not acknowledge that it has a lot of emotional significance, but it will be something that is clearly triggering. The onset of someone who has a manic disorder, more likely you won't really find you won't find an interpersonal cause. I guess sometimes you'll see that people started taking recently like an antidepressant medication. There's mixed evidence on whether or not that can happen. I have had patients who've come in though, and they're like, that's been the story, that they took an antidepressant and then, 4 days later they were in a hospital, So that is something that can happen. You'll see, but you're not going to reliably see in people who are having a mania, like an emotional trigger like that.
Absolutely.
Yeah.
Also, when I see what you said is exactly right. In the borderline, there are episodes, they're a lot like what I previously described. They're often triggered by some sort of interpersonal conflict or imagined conflict, friend, family member, romantic interest. And often they're also abruptly kind of extinguished if there's some sort of resolution to that interpersonal conflict. A bipolar mood episode does not follow that pattern. I mean, could somebody go manic or majorly depressed because of some sort of interpersonal conflict? Sure. Oftentimes you see, in a bipolar mood episode, there's an onset. It lasts at least a week. I think the average manic episode lasts like 6 to 10 weeks.
Yeah.
You have a constellation of these symptoms. There's this, as far as what I was describing before, the racing thoughts are not necessarily focused in on whatever interpersonal conflict there is. There's racing thoughts as far as like grandiosity. There's pressured speech. It's a fixed mood.
There's a lot of goal-directed activity.
A lot of goal-directed activity.
They're trying to make things happen. And I feel like, when people are suffering from borderline, more often it's not like they're trying to create things. It's more like they're ruminating about the relationship, or ruminating about their status in life, or ruminating about their failures or something,
Absolutely.
And you said, I think earlier that they're more anxious. And I think that in a subjective sense, that's very important. Like there's a real anxiety quality that's very present in mood episodes of people who are suffering from borderline compared to bipolar disorder. Like the closer you get to a true mania, I mean, the less anxiety they have. I will never forget
in fact, they're fearless. Yeah,
exactly. They're fearless. No, this is the first time early in my training when I was in the psychiatric emergency room, I ran into a patient who was in the psychiatric emergency room who, let me see, how few details can I give and still get the picture here? Because I don't want to give too many. But this was a man who had been in like a school for something that was very meaningful and like personally meaningful to him and his community, and he had gone through high school and was in sort of a college setting, was something that was going to be really important for him, and he was clearly like, it made a lot of sense for him and his family. When I talked with them, we're like, yeah, this is very consistent, that's what he wanted. When he became manic, not only did he drop out of school, he dropped out of school and he started just wandering the country on foot, like the United States, just wandering on foot. And he was homeless and he had a lot of like sexual encounters that were very unsafe as well. And when I caught him, he was like very sunburned and his hair was all in a tatters. And this was a kid who'd come from like a family where, like I say, everything was organized and he had a plan, right? But when I went into the room with him and talked with him, and he looked completely disheveled and he was in a tatters, and I'm talking with him about I ask him where he's been, and he gives me this story and he tells me, how he left school and he'd been wandering around and all these things happened. And like, as he's telling me this very, very depressing, horrible, sad story, not only was there no anxiety, he was grinning from ear to ear. And like, he was so happy that I couldn't stop being happy either. It like bled into me. Like I was infused with probably like one of the happiest moments of my life. Mm-hmm. And it was so weirdly discordant because in a part of my mind, I'm like, this guy's life has fallen apart. And after I stepped out of the room and closed the door, then like, the sort of like the overwhelming infusion of happiness drained from me. And I was like, oh my gosh, this is horrible. And so like, not only is there no anxiety, but like they can, like in a really serious mania, like it can be way too euphoric.
It's life-threatening. They either end up in jail, the hospital, or unfortunately dead.
Yeah.
Like you said. The anxiety component is that's absolutely right.
Total.
And I don't know if I've ever
so
actually describe it as explicitly as that, but like the anxiety component
Mm-hmm.
that's runs through the episode of emotional dysregulation in the borderline is massive.
It's huge.
And that's what drives the racing thoughts,
and
the
sleep,
insomnia, the arousal and energy levels, the impulsivity. It's actually, they're acting compulsively, right? It's from a place of like pure fear and anxiety and to relieve distress.
And it's like reaction,
Absolutely.
And like the mania is like very like it's very proactive, It's like they've got all these great ideas and like they're not sleeping, not because they're worried about anything, but they're not sleeping because like, look, I got to build these tables.
There's not enough time in the day.
I got the best table plan ever. I bought a bunch of wood. I'm just going to become the most world-renowned table maker.
Exactly.
And they're just building tables,
Absolutely.
And they need all hours of night to do it.
Okay, so we've talked about like comparing and contrasting emotionally dysregulated episodes in borderline versus a manic episode in bipolar. If anybody has any questions about that, leave them below in the comments. We'll answer them. I would also, while we're here, love to contrast borderline personality disorder with complex PTSD, CPTSD. So please do that. Yeah. What is CPTSD? What's the definition of a complex trauma? And how do you differentiate between these two diagnoses?
So that's a tough one. That's a tough one too. What I think is most interesting about CPTSD and then this idea about overlap with borderline, because that's what, so I mentioned earlier that in the, kind of around the turn of the millennium, there was a lot of discussion like, oh, is borderline actually just a different variety of bipolar disorder, right? And so now there's this new idea that's come out in the past few years called complex PTSD. And, there's people who really feel confident about this diagnosis. And then there's another group of people that say, but isn't this just another way to talk about another name for borderline personality disorder? And what I think is fascinating about borderline personality disorder in particular is like how many times there has been some sort of a push by some people to either like rename it, or to reclassify it or something. And it's because inside the mental health world, it can be difficult working with patients who are borderline. And so there's like a stigma, and I think that also in like the legal system, there's a stigma for people who have borderline, and that can cause problems in people's lives. And so, and there will probably, I think, always be a stigma, because borderline really, it really, these things really do cause a lot of distress in people's lives and in the lives of the people around them. So it is a huge deal. So there will probably always be people trying to rename it, or to change it. But what's interesting is that, like I say, Gunderson wrote that article really showing that there's a clear distinction between borderline and bipolar, even bipolar 2, and I think, I don't know where I think the jury is still out. I suspect that there will probably we'll get this new category of CPTSD, and it will probably be its own unique thing, kind of like bipolar is its own unique thing, but I'm not sure. So I think the time will tell. But the idea of complex PTSD is that some people have symptoms of PTSD. And they mentioned, like the dissociation, and then a lot of the mood symptoms that are common to PTSD, and the avoidance symptoms that are common, and then the re-experiencing symptoms. Those are the 4 main categories of PTSD symptoms. And so people will have those, but when you look for like an index trauma, maybe they won't have a specific index trauma that really like qualifies as like a solid, this one thing is PTSD. Or maybe they will, but they'll have like 50 of them, or maybe it'll just be their entire childhood, just nonstop growing up in a very difficult situation. So complex PTSD is this idea that the PTSD may look different, and there may be more serious symptoms resulting from ongoing continuous trauma that happened for a long time in their life.
Ongoing continuous trauma. Oftentimes it's emotional trauma, and oftentimes it's spanning over major developmental periods of somebody's life. And often that emotional trauma is related to an attachment figure, or somebody close in their lives.
Yeah.
So you have this complex trauma that leads to these PTSD diagnosis. Again, it differentiates from a sort of like classic post-traumatic stress where you have this like identifiable index trauma.
Yeah.
And the CPTSD, again, if we're talking about borderline and how that is formed and birthed out of relating to attachment figures that maybe were unpredictable, that maybe weren't securely attached to you.
Or neglectful.
Certainly that is a form of complex trauma, right?
Yeah, absolutely.
But not, and I would say personally, it's easier for me to differentiate between a borderline patient and a bipolar patient.
Yeah.
I think the lines are more blurred with CPTSD, because I suppose if CPTSD is like this big umbrella, perhaps borderline can fall underneath it.
Maybe.
Yeah.
So I think we'll see where I think this is still a question that the research is going to really tease out for us. There was some study, and I didn't get into the details of it, so I don't know, but just vaguely, like that there was a statistical study that was trying to cluster all 3 of these disorders actually, and it seemed to say that there were 3 distinct clusters. So maybe as time goes on, that will bear out, and we will see that. But it's an ongoing question of research, and we'll see what people do. I can see it's really hard for me as well to distinguish, because there is a lot of overlap. In borderline personality, you'll have these moments of like, almost like a paranoia that can be kind of separated from reality, or dissociation. That's right there in the DSM criteria. And then that's a classic issue with like ongoing complex trauma, is dissociation is sort of a really common way that they defend against their feelings. So there's an overlap there. The mood symptoms, there's a very common for people with borderline personality disorder. It's like 80% of people will have a comorbid depression diagnosis as well, so you're going to have those mood symptoms are common. They're inside PTSD as well, or CPTSD. And then avoidance, that just makes sense. You're going to have a avoidance of triggering issues or things that trigger you or bother you. And the re-experiencing, I guess that's not included in the borderline.
Bingo.
Be a borderline. So is that the distinguishing feature, or is that just like a facet that came out in the DSM? Because there's 2 things. There's the disorders, there's the cluster of symptoms that the DSM has decided, and then there's sort of the actual experience of people in the world. And do these things really actually divide into discrete categories that are different and that respond to treatment differently? or do they not? So I think we'll have to. I think we have to wait and see, and more time will tell, and more research will let us know.
The lines are very blurred because on one hand, in CPTSD, you have the re-experiencing, whether it's nightmares or just kind of flashbacks.
Yeah.
And in borderline, you'll often see like this compulsive mental review from prior social interactions in which you're trying to make sense of it. The borderline patient will spend significant time in distress about some sort of interpersonal, something that happened interpersonally, an interaction, and they will sit there and compulsively mentally review and ruminate and obsess and relive to try to make sense or comfort themselves from a prior social interaction. So the lines are blurred. I could talk to you all day about this.
Yeah.
If you guys want us to do more on CPTSD and like the overlap with borderline, we're happy to do that. We're not going to cover that too much in today's podcast. So if you guys want more on that, leave that down below. Any like final notes on CPTSD and borderline?
No. Did you want to? We haven't done treatment yet.
So treatments. So treatments of borderline personality disorder. Okay. What are they? Let's talk about therapy first, then we'll talk about medications, and we'll contrast it with meds that we use in borderline or bipolar as well.
So conveniently, the American Psychiatric Association just last December released a new, like a very comprehensive review of all of the extant literature of what works best for borderline personality disorder. And they did say pretty conclusively, and this is consistent with what, like John Gunderson has been saying and other people have said, and also with my experience, that medication is second line or not really. Anytime you want to use medication in someone who has borderline personality disorder, you really want to be clear that like medication will not fix the issue. Medication does not address any of the underlying patterns or any of the underlying defenses or any of the underlying problems. It's not going to take away like the chronic sense of emptiness that they have. It may help for specific issues in a time-limited fashion. So medication is second line, it's secondary, it's not to be emphasized. And if you do start it, you almost always want to start it with a plan to stop it at some point.
Hugely important. Yeah. Let me repeat that for the audience. If there's a patient that has borderline personality disorder, the primary treatment is therapy. Medications are secondary. I totally agree with you. Absolutely. And so does this, what is it, like a meta-analysis review article or something?
No, it's the APA.
Oh, the APA.
Yeah, but it's a review, right, of all the literature. So yeah, it's and that's the current recommendation. And what's interesting is when I was in training, everybody always, DBT was the therapy of choice, and it's still listed.
Which is what? Explain to the audience that doesn't know.
So DBT is a dialectical behavioral therapy. It's a therapy that was created by a therapist named Marsha Linehan. It's sort of derived from behavioral psychotherapies, and it is sort of it positions the therapist as a sort of a coach. It sort of has this idea that the borderline personality disorder is a situation where people have a bunch of skills that they did not develop, during their developing years, and that if you work, you can focus on developing these skills, and these skills will be useful in managing the emotional distress that can be very disturbing to people who have borderline experience. And it can be very helpful for getting along with people because, and it can be helpful for figuring out a way to get your needs met, to actually get your needs met. Because like we talked about the double bind communication before, double bind communications are things that people with borderline do because they're trying to get their needs met. But gosh, it's a really horrible way to do it because it puts the other person in a lose-lose situation. And the people with borderline rarely realize this, and they're doing it kind of, just instinctively, right? So what DBT does is it sort of teaches you, here's a way how you can communicate with people that's not a double bind. Like that's not their goal, but like basically that's one of the things that they do. Here's a very clear way to state your needs and to talk to a person and to be respectful of their distance and to understand the boundaries. And if you go through these steps, then this is how you can deal with people. It's very concrete. It's very, the DBT therapists are very, very available and very interactive, and they really will help people debrief what went wrong and try to find those sort of stuck points and to find the points where the emotions kind of went off the rail. It's a really great therapy. I have a lot of confidence in it, and it's still one of the top recommended ones, but it's not the only one actually.
And before we get to something else, so the D in DBT means dialectics, right?
Yeah.
What does that mean?
Well, I first heard of dialectics in high school from, I was like an old philosopher, sort of the idea of like, one side and then the opposite side. And so the reason I think she named it this was because she wanted to help these people with borderline learn to hold opposite ideas that seem to be mutually exclusive together in their mind at the same time, which is actually it's the opposite of splitting.
Bingo.
Right?
Exactly.
Yeah.
Exactly.
That's what you wanted to get
a
to.
little exercise I tell patients, right, that often split and they get very anxious. Like the classic example of my friend hasn't texted me back. I messaged her 2 hours ago. Yeah. She must hate me. Now I'm totally in a sense of arousal. I'm totally anxious. I can't handle this. I need to do something, right?
Right.
And then I tell them, okay, well, have you ever received a text message from somebody you love and you were busy? Like, let's say you were driving, you didn't have time, you had to focus on the road or something like this. So you told yourself, well, let me just get back to this person in 2 hours when I have time. They all say yes.
Yeah.
But they can't occupy it, right? So I try to flip the script and put them in the position that their friend most likely is in and say, well, have you ever delayed returning a text of someone that you loved by 2 hours because you were unavailable? Yes, doc, I have. So why are you assuming that this person now hates you and is ghosting you or has some sort of problem with you when he may very well just be busy and yes, has seen your message, but is going to get back to you later, right? People are not all good or all bad.
Right. People
that love you can engage in behaviors that you might deem to be bad. So that's one little small example. So I think like the dialectics literally goes after that core kind of feature that you see of splitting.
Yeah, it does. It tries to help you to see people as complex individuals.
People are complex.
Who can love you, but also be distant for a minute because of some reason.
People are complex. People are flawed. Good people do bad things sometimes. People make mistakes. Nobody on this planet is all good or all bad. And to occupy that sort of like that way of thinking and conceptualizing another human, as we previously discussed, borderlines have a lot of problem with that.
Yeah. And it is, and it doesn't.
People are risky.
People are.
Relationships are risky.
That's why they're afraid of the intimacy.
Exactly.
It doesn't have to be all good or all bad. It could also be that your example is a great one because it's like it's all or none. Either they love me or they don't love me. So if they're texting me, then they love me, and if they're not texting me right now, then they don't love me, right? So it's that all or none thing, And so you're trying to introduce the ability to add some nuance to that. That's what you see with dialectical behavioral therapy. And guess what you see with the other stuff? Same basic thing, just different ways to teach it. Dialectical behavioral therapy is a real coaching-based way to try to do it. The other ones like mentalization-based psychotherapy, mentalization-based therapy, the idea to mentalize is to be able to imagine the mind of another person and to realize that mind is different from your mind. So that's kind of also in a way what you're asking that person to do. Like, can you imagine the mind of this person who's not writing you back? And can you come up with other explanations as to why they might have not written you back right now that might not be just because they don't love you anymore, or they're trying to secretly let you know that they're furious at you and they want to break up with you right now or something.
Yeah, and mentalization is also fundamental to empathizing.
It is. It's a fundamental thing, I think, for a lot of life, because we work with people and you really need to understand that you don't know what's going on in other people's mind. You don't know. Mentalization-based therapy takes a real stance of, I don't know what the other person's doing. Let's be curious and try to figure it out. Let's not jump to conclusions.
Now, borderline personality disorder is something to take very seriously.
Yeah.
It's a trouble relating to others and to relating to yourself. And it carries with it so much pain and suffering. Humans are relational beings. We're social animals.
Yeah.
So we definitely want to take this seriously, and we definitely want to get this patient all the care that they can, that we can. So therapy is the first line. We have the DBT, dialectical behavioral therapy, that's typically first line. There's other forms of therapy like mentalization therapy.
Yeah.
What are other forms of psychotherapy that you see effective in borderline? And then let's talk about ways that we can provide some of these patients with relief using psychotropic medications.
Yeah. So the other two, so the APA's release said, they mentioned dialectical behavioral therapy, mentalization-based therapy, transference-focused psychotherapy, which is a sort of like a psychoanalytically derived therapy that was made by Otto Kernberg, the guy who I was talking about earlier in the podcast about, he was the one who wrote one of the original papers sort of explaining or defining the borderline personality organization. So his is transference-focused psychotherapy. Transference is the feelings that a patient has in the room with the therapist as they're working with them. And so in transference-focused psychotherapy, you focus on the transference, and that should work in the same way to help build mentalization and to be able to help hold the opposite beliefs in mind as well, because you're doing it in real time with the therapist in the room with you, trying to see how are your tendencies toward borderline thinking, are they coming up in between you and the therapist?
Yes,
so
absolutely.
That's another good one. And then there's this other one called schema focused psychotherapy, which I'm not that familiar with. My sense is that it's pretty common in Europe. But I don't know too much about it. So
me neither. And then when you Dr. Kanell talked about like the transference-oriented psychotherapy. Now, what did I just say? I said that humans are relational beings. We're social animals. It's all about how we relate to others and how we relate to ourselves. And you spoke previously about this template that's been developed over our lives as to how we are interacting with other people. That template developed when we're, major developmental periods of our life, when we're young, maybe because of our attachment figures or whoever else we're next to, like often, right?
Or whatever your caregivers, maybe older siblings,
So it's a dysfunctional template on how to relate to other people.
In your current context.
And when they show up in therapy, they end up screwing up this relationship.
In the same ways.
In the same ways they screw up the relationships in their lives. And it's up to the psychotherapist to pick up on this, bring it to the attention of the patient, block their projections. You'll tell us what that means in a second.
Yeah.
And also work with the countertransference. So the transference is how the patient is feeling towards the psychotherapist.
Yep.
The countertransference is how the psychotherapist is feeling towards the patient, which is invaluable, right?
Yeah.
The way you're making me feel, oh my God, you must be doing this to other people. If I'm pissed off and angry at this patient, it's my duty to bring that up and be like, listen, is this the relationship you're inviting in other aspects of
this
your life?
Feeling that you stirred up in me, does this happen? Is this happening with your partner? Does this happen with your boss? Does this happen with your cousin? Is that why you're,
So what's defective with this template on how you're relating to others? And how are you screwing this up now by bringing this template into our relationship as patient and psychotherapist?
And can we help you to change that?
Now, it takes a lot of skill to do this.
Well, and when you bring up countertransference, that's why it's so important for a therapist to also be going to do their own therapy, because you need, as a therapist, to have as clear of an understanding as you can of your tendencies to react to things as well, because you want to be able to work to differentiate between, like, okay, the feelings that are coming up right now, is this because I had an older brother, like, as a therapist, right? And working with the patient, you want to know, like, am I having a feeling right now because this is evocative of like something that happened during my childhood with my parent or my brother or my cousin or something, right? Or is this something that's coming up because this is the patient bringing it in and they're really stirring it up in me,
Absolutely.
So it's absolutely critical that the therapist be able to do this so that they can use their countertransference as useful information to try to help the patient out. So that's one thing. And then I had a patient, I think, come in once who seemed to have the sense that, like, they had, like, I think, watched some videos or heard about transference, and they had the sense that transference was, like, not good, or was a sign that they had a bad childhood or something. And I want to be clear that that's not the case at all. transference is what you said. It's just a template. Like we use these templates to interact with everybody. If you don't believe me, like imagine that you're driving on the freeway and someone does cut you off. You know, if someone you've never seen before has cut you off on the freeway, how do you react in that moment? You know, what do you imagine that person is like? Do you imagine that they're neglectful and dismissive and they're just not paying attention, you know? Or do you imagine that they're like malicious and angry and like trying to hurt people? Or do you imagine that they're like, you know, aggressive and like just bowling people over without noticing the other people? Whatever it is that you imagine on this person that you've never seen, probably because they're in the car and you can't even see their face and you don't know anything about, that idea is the idea of transference. You know, you come in to see a therapist and you don't know them at all, but you imagine that there is some sort of a way. And that's what transference is.
And the opposite. Some psychotherapists, they think that if they get angry at the patient or they have some sort of negative feeling towards the patient, that sort of countertransference, they feel like they're doing something wrong, right?
Yeah.
They try to dismiss it.
Yeah.
And how do I put the anger I feel towards this patient aside so I can be a good psychotherapist? Wrong. That anger and the way that you are being made to feel is so hugely important.
It's critical
and
information.
That's half the data that you're working with.
Yeah.
Now, you want to be doing your own supervision, your own psychotherapy.
Absolutely.
Make sure it's not stemming from something that you're bringing into this. You want to work with what the patient is bringing in.
Yeah.
But that countertransference is gold, right?
It's super important because that's got to be how other people in their life feel.
Exactly.
And
now,
that's what they're missing out on.
Maybe we'll nerd out. I'll bring you another time. We'll talk about like object relations theory.
Yeah.
If the audience is interested in that, I know, it's a little bit, we'll get into the weeds in that if you guys want that.
Point, yeah.
Leave some comments down below. And this is also a little bit too in the weeds, but this is for my own sort of like curiosity.
Mm-hmm.
Talk about blocking projections as a psychotherapist. What does that mean? Tell me more about like blocking projections. What is that?
I think this is an important thing that you want to try to learn how to do when you're doing psychotherapy is when the patient is projecting on you, you know, first is try to figure out what is the projection. You really want to define it, you know, and then you want to try to see if you need to double check, make sure that you weren't playing into that at all, right? Because if you were, you might need to, if there's an apology that's in order or something, that's important to be able to do.
Can you give the audience a specific example? Because we might have lost them. Give an example, if you can think of one, of like a patient trying to project something onto you. I can give an example too if you want.
Sure. I mean, what comes to my mind is the idea that like let's say that you had to cancel an appointment for some reason, like a personal reason, like maybe you had to take a day off of work. And if you come in and then the patient, you know, is pretty irritated with you that you weren't there that day, you know, it'd be like, well, so what's on your mind about, you know, how are you feeling towards me? Or what do you think is on my mind? They might have a sense that like maybe you canceled the appointment on them on purpose, you know, because you didn't want to see them that day. Maybe they told you some really difficult feelings the last time they saw you.
Bingo. So here, Dr. Kanell had to cancel an appointment with the patient because he had some sort of personal matter completely unrelated to the patient. Mm-hmm. The patient now shows up on the next visit and is upset because now this is where the projection comes in, right?
This is where the projection comes in.
They think if I was a psychotherapist seeing myself, and I am like difficult to deal with, then I wouldn't want to see me. So I'm just going to flake on myself because I'm just like not pleasant to be around. So this idea of I'm going to flake, the psychotherapist is going to flake on me because I'm annoying or difficult to deal with. They're projecting that, right? Judgment, not treating the patient well, right? They're projecting that onto the psychotherapist because they feel like they might, do it themselves if they were the psychotherapist. Is that right?
Yeah, that's one way. That's one way that it could happen. Now it could be like in the middle of a session, maybe you would say something that, you know, that you're trying to develop some insight in the patient, and then they might feel like, oh, you said that because you're mad at me or something, right?
Yeah.
You know, like or you're critical. That's a pretty easy one too, actually. Like the patient will tell you about something that happened in a relationship that probably did damage to the relationship. And you're trying to say like, okay, so when you said this to your partner, you know, did you notice that this really hurt your partner? Because it sounds like it really hurt him or something. And then like, oh, so you're trying to say I'm a bad person? It's like, no, not trying to say that. Just trying to take a look at what the objective reality of what's happened.
Yeah.
So projections can happen, and then I think one thing that you want to learn to do in psychotherapy is you want to learn to sort of comment on the process as it's happening. That's, I think, the extra information that you can get that's different from normal life. In normal life, you're usually just living and talking with people about the things that are going on. And it's more rare, I imagine, that people will talk about how are we talking together and how are we interacting together and what is the flow of feelings and information here, like to take sort of a meta stance.
Oh my God,
it.
I love this. This is the beauty and the extra layer of communication that we engage in psychotherapy is that not only are we communicating, we're talking about the communication real time.
Yeah. And so that's why when a patient does come in and project, you really want to explore how were they feeling and what were the ideas that they had. And then you want to try to see if they can find any ways to think different or new ideas. You'll find that a lot of the people who are suffering from personality disorders, the more severe the disorder, the more rigid their thinking tends to be. And so you really want to try, this is what's common to all of these different psychotherapies for people with borderline, is that they're trying to introduce flexibility of thought and flexibility of belief. And as your thoughts become more rigid, you're super sure that the psychiatrist canceled that day because they just couldn't see you again because it was such a difficult session that last time, and that it's all about you, like that's so sure and so rigid, and the reality is most people do things for many different reasons. There's always multiple causes. There's sort of a psychoanalytic idea, this theory of multiple causation, that these things that actions are overdetermined because there are so many reasons inside why you might choose to do a certain thing. Why did you buy this car? Why did you choose this job? Why are you going out with this person at this time? There's never just one reason, So why was the appointment canceled that day? There's usually more than one reason. And if you can introduce some flexibility of thought, that really helps with people. And then if you can introduce the ability to mentalize, to try to imagine how another person might feel and to have some sort of empathy for that, then that can really help people as well. So that's sort of the goal of a lot of these psychotherapies.
And people try to, patients oftentimes, the one thing that's easily noticeable by me is they try to project negative judgment.
Yeah.
So they will say something that they're clearly judging themselves for, like a negative judgment against themselves, or maybe their parents are.
Yeah.
Well, doc, I kind of decided to like really drop out of this like radiology like school I was in because it wasn't really like what I want. I know that this is like the third different sort of vocation I've been tracing. And then they wait for me to judge them in the way they're judging themselves, or usually like their parents or like whoever their family is judging them.
Oh, that's too bad.
Why do you keep jumping? Why do you keep jumping from something to something? Just
Yeah.
get a job, pay your bills, blah, blah, blah. And then when they don't see that I'm like jumping to judge them in the way that they and their family might be judging them, I feel like I am blocking that projection, right?
Yeah.
It's just a pure neutral stance. So tell me more about that. Is this in line with your values? What do you think about this?
Yeah.
I'm blocking that projection where they just assume that I'm going to judge against them the way they're judging against themselves.
I think that's a really important thing to be able to do. And it's important for patients to really, like, it's easy that's another, it's easy to imagine that everybody in the world thinks that you should be doing the thing that is the good thing. But I mean,
the quote unquote good thing.
The good thing, right? What you were taught was a good thing.
Yeah.
But like people have different definitions of good things. And like as a psychiatrist, like when I'm treating people, my goal is not that you do the good thing. My goal is that you live a life and that you feel okay with it. I recently read, I know this is pretty off topic, but I recently read The Myth of Sisyphus, which is a paper, which is an article by this guy named Albert Camus, I think. It's like he's like Camus, a French guy. Yeah. But I read it and it was fascinating because it's existentialism. It's just, at the end of it, I'm like, you know what? Yeah, you can't. You believe what you want to believe, but like at the end of the day, the physical reality is, look, we're all here, and you got to get through it,
Exactly.
You can either get through it or you can't get through it. And however you get through it, like if you can get through it in a way that lets that small voice inside you, be more satisfied, I think that's nice. Whatever it is you have to do that,
Yes, exactly. And don't pull me into your template, right? Don't pull me into the template that was formed with you whatever age. I'm not getting dragged into your template.
I want you to figure out what you want and then to be happy with it. And if that's not going to a radiology school or whatever your thing is, that's fine.
And they try.
Like, I don't have any bones in this race.
They try so hard to pull you into the template.
Yeah.
They'll elicit anger out of you or sadness or some sort of emotion to pull you into their dysfunctional template. And you have to resist
there was
going and playing into their dysfunctional template and repeating the repetitive dysfunctional patterns of relating to others that they've been engaging with their whole life with other people, right? Well, so don't get pulled into their template.
Well, no, and this you talk about them trying to draw you in, and I
unconsciously
think,
usually.
Oh no, most of this is unconscious, or all of it maybe. But there was a paper that was written by some people at the Chestnut Lodge a long time ago, where they were treating people with this was before they called it borderline. It seems likely these are borderline patients. And one of the things that they mentioned about them is that they really will draw you in. Like they're looking for connection, they're looking for someone to care about them. They're looking to they want the intimacy, and then they'll get afraid of it later on. But like in their efforts, they really will do what they can to bring you in and to bring you together. And so they'll really try to build that connection. And they really work hard at it, and they do find people, but then that's why they say the relationships are both intense and then they blow up intensely, right? Because they'll start quickly and then they'll draw the people in and they'll really connect with them. And then they'll realize that they're starting to build intimacy, and they'll become terrified at the intimacy, and then they'll do things to destroy the relationship. And then the relationship will fall apart dramatically as well. So, but this is, you talk about the drawing you in, that's something that you really will experience.
Absolutely.
Bring you into it, and then we all want connection.
Now, what medications do we use for borderline personality disorder, and how do they overlap with bipolar? So
when I was in training, there was a small study that had come out of like less than 30 people saying that it seemed like lamotrigine might be helpful generally just for people with borderline. But then they did an expanded study of under 300 people, and those positive effects didn't really bear out. So it seems like there's not really good data to say that it can be helpful. I mean, you can try it out if you'd like. But what I said earlier is what stands. Anytime you start a medication for someone with borderline, the first thing you want to talk about is how the recommendation is that we don't do medications long term. And so if we start it, ideally you want to have a plan for how to stop it as well within a time limited fashion. So you can use medications to treat specific things that come up in borderline personality disorder, but you can't find a medication to just treat the whole thing. So if they're depressed, I mean, you could consider trying to treat the depression, but the recommendation again is that you go get treatment for the borderline personality disorder through these therapies, and then the depression will likely resolve because it is likely secondary to the borderline personality organization. So antidepressants are less commonly considered as useful. Mood stabilizers, you can use mood stabilizers, but they're also not considered as useful because people with borderline personality disorder tend to have very rigid thoughts. We're talking about this idea that their partner hates them now because they didn't text them back, right? So and they're so sure of it. That's a rigid thought, and it's not really flexible. I'm thinking, well, are there other possible reasons he didn't text me back? So you can help with rigid thoughts they're called antipsychotics, but they're just, it's another category of medications. But you can use those, I think, in a time limited fashion. And antipsychotics can also help sort of hold your mood together a little bit in the short term. So I think a low dose of an antipsychotic I found to be a little helpful. Mm-hmm. But you don't want to use it long term. You don't want to rely on it long term because it won't be helpful long term. And then you really want to stay away from benzodiazepines because a lot of people with borderline have issues with impulse control, and benzodiazepines are more likely to have a side effect of decreased, poor impulse control. So you're going to treat their anxiety with that, but then, they're going to have more impulsivity potentially, and then that could really destroy things in their life.
Yeah, excellent point. So lamotrigine for borderline personality disorder. Oftentimes in practice, we do prescribe it for the borderline patient, but the evidence does not show that this is an effective medication, like better than placebo for the borderline patient.
That's right.
There's like a recent meta-analysis by JAMA. I mean, there's the evidence out there, but honestly, like in practice, when the borderline patient comes to you and they're in DBT therapy and you know that medications are second line, sometimes lamotrigine is started.
And just because it's not recommended doesn't mean that it might or might not actually be helpful for any given person. Everyone has their own subjective response to medication. So if I inherited a patient from another psychiatrist and they had a borderline diagnosis and they were on lamotrigine, I'd be like, probably just continue it if it's helpful, and then talk with them about how helpful it has been and try to get a good sense of what it has done for them. I think what's important is you want the patients to have a really clear idea of how the medications have been helpful and what specific things they have done for them. Because if they're not sure, then you do want to try to use fewer medications. One of the things that is known that was in the APA guidelines is that as the number of medications that are getting prescribed goes up, the overall improvement in their life seems to go down. So we don't know where the causation goes on that, but that does seem to indicate pretty clearly that you're not going to get more bang for your buck out of more medications.
Absolutely. As a judicious psychiatrist, you always want to take a detailed history of the medication and whether or not there's been a noticeable improvement in symptoms because of the medication. You do not keep a medication around that is worthless, right?
Right.
And polypharmacy, being on multiple medications, as Dr. Kanell just mentioned, is linked and does correlate with worse outcomes.
Yeah.
Now, in contrast, lamotrigine can be a fabulous medication in bipolar disorder.
Absolutely.
And I would say more effective and better chances of success with lamotrigine anecdotally in practice that you might even see in the evidence. So what do you think about lamotrigine as far as a bipolar medication?
I like lamotrigine as a medication. I feel like I have not seen a lot of side effects from people taking it. It's been reliably like a good medication to turn to that has been helpful for a lot of people with a bipolar diagnosis.
Yeah.
Really helps with bipolar depression.
So it helps with bipolar. Sorry, I'm interrupting you. It's indicated, FDA indicated and approved for bipolar depression.
Yeah.
So, but it can also help with the manic episodes.
Yeah, it should help prevent another manic episode, I think.
Yeah. And an important point here is that controlling the depressions will also help control the manias. Because overall mood stabilization and overall reducing the chances of quote unquote, not quote unquote, mood episodes, including depressions and manias, does overall stabilize the patient.
Yeah, there's been some evidence. There's good evidence showing that you want to try to you want routines and sort of more regimentation for people who have bipolar disorder. They're gonna do better with, especially you want them to be sleeping very well. You can get sleep disturbances with depression, of course, and so you want people to be able to continue to have good, high quality, restful sleep, because it seems that getting poor sleep and having that kind of internal sleep clock get separated or off kilter, that seems to be something that can tilt people into a manic episode.
Oh yeah, big risk factor for going into a manic episode is insomnia and a series of sleepless nights.
Yeah.
Now, Seroquel for sleep and mood stabilization. What is your take on Seroquel? Do you use it in bipolar or borderline personality disorder? What should we think about Seroquel?
So Seroquel, I'd say like a low dose Seroquel is something that you could use, for example, in a time limited fashion for people with borderline personality disorder if they're having a lot of that emotional instability. That can help decrease. They can take the edge off. It can help them deal with some of that, maybe decrease some of the impulsiveness. And then for bipolar disorder, I would probably use higher doses. And then my goal would be that it would be using Seroquel to really help them to sleep very well. And then also to prevent a manic episode. It is approved for that. And it can be, I think, quite useful for that. But you do need higher doses.
So what doses do you use in borderline? What doses do you use in bipolar?
I mean, you work with the patient, but in my mind, I guess the sort of a rule of thumb that I've got is I'm like sort of like I divide it around like 100-ish, you know, or like 100, 150 or 200, somewhere around there. Like anything above that is more of a bipolar use, and then anything below that would be more of a borderline sort of
what
use.
dose does Seroquel become more antidopaminergic?
Over 300.
Over 300, exactly. Now, I like what you said as far as time limited. Now, Seroquel is a fabulous medication.
Yeah.
Time limited is right because almost always you have metabolic side effects.
Yeah, no, Seroquel, it can be a tough one. People will gain a lot of weight on it, and you can have risk of diabetes and stuff.
Yeah.
So you have to be careful. Other than the metabolic side effects, and then the drowsiness, you take it at nighttime, so it actually becomes a sleep aid rather than something that causes drowsiness. It doesn't have a lot of. I haven't seen a lot of patients complain of other side effects from it. You know, they're not getting the tremors and other stuff.
If it didn't have metabolic side effects, it'd be one of the most perfect medications we have.
It's a nice
but it
one.
does, so it's not perfect at all.
No.
I must say the amount of patients I have on Seroquel long term, I probably can count on two hands out of the 1,000 patients, whatever I have.
Yeah, you will see the weight go
rarely
up.
manage someone long term on Seroquel because the metabolic side effects are real, and these metabolic side effects extend past increase of appetite. So you could tell me, Doc, I'll get on Seroquel. I'm going to watch the munchies. I'm not going to overeat. There are derangements in your lipids, your cholesterol, your blood sugar. There are derangements then that can occur even if you do not change the amount of food that you consume.
And then the other thing is, even if you make a very valiant effort to change the amount of food that you consume, it really does change your overall experience of hunger, you know? So maybe you were able to manage these things beforehand, but for some, and this is not true for everyone. I've had some people, I've got people who've in a more difficult situation around higher doses of Seroquel and their weight hasn't budged an inch, right? But that's the exception. The rule for Seroquel is that you're more likely to have changes in hunger. It's going to be more extreme. You're going to be wanting to eat things that are going to be, you know, higher calorie and like less nutritional content. It's going to really cause problems for you. And then, in addition to that, even without that, you can still have metabolic issues around that.
What do you think about lithium?
Lithium's a great medication. It's really good for it was the first medication for mania, and it's still one of the best medications for mania.
Some of my favorite medications to prescribe are the oldest and first, lithium and Prozac.
Yeah. No, they're
not rarely together, but lithium. Talk to me about, do you ever use lithium in do you ever use lithium in borderline personality disorder?
I can't imagine any situation where it would really go to lithium as a first line in borderline personality disorder. Lithium is the classic mood stabilizer. You know, we discovered it by luck from a random scientist who was like, maybe this will work. You know, they thought that like bipolar disorder had something to do, I think, with uric acid, and like there was a gout treatment that had something to do with lithium. I don't remember the details, but so he just tried using like really high doses of lithium in the animals, and then he tried using it in humans, and like it did help. So why? Who knows why, but it works well, and it works really well for breaking a manic episode. And remember, manic episodes, I'm talking about, you know, these people are getting hospitalized or they're ending up in jail, and they would never have ended up in jail before. They're at risk of dying, and these are people whose lives are totally derailed. You know, and lithium to be able to stop the manic episode, that's a lifesaver.
It's a godsend.
Yeah.
Does lithium cause weight gain?
It can. I'd say I've seen that more in the research than I have in like my clinical practice. I do see it every once in a while, but compared to other medications, you know, like compared to Seroquel, for example, I'd say in my experience, lithium really rarely causes weight gain.
Same. And the more evidence that comes out about lithium and its side effects, the less likely we learn that lithium is to cause weight gain.
Yeah.
Yeah.
I think I had in all of my career, I can think of one patient who was in a criminal justice setting, and he was only on lithium and was gaining weight. And I mean, at the end of the day, was he gaining weight because of the setting? You know, was it like a locked setting, or was he gaining weight because of the lithium? I'm still not sure.
Mhm.
But that was the only medication he was on, and he was gaining weight. So
Yeah. What other medications do you popularly or commonly use in borderline personality disorder?
I think that, the other meds that I would use in borderline personality disorder, you mentioned like a low dose of Seroquel. I also would use like a low dose of Abilify.
Mind you, I never use Seroquel. I rarely use Seroquel in borderline
Mm-hmm.
because borderline patients typically, as far as like their sense of self, also have a lot of hesitation on getting a medication that can lead to weight gain.
Yeah, I agree.
Yeah. And
No,
then you were
so
saying Abilify.
so
Yes.
that's why usually Abilify is what comes to my mind, because Abilify is less likely to cause weight gain. It's in the same category as Seroquel, but it's less likely to cause weight gain.
It's a neuroleptic medication, and correct me if I'm wrong, but it's more likely to have weight gain if a child is taking Abilify rather than an adult.
That may be the case. I don't.
Yeah, it
I don't
is.
work
Yeah, I
with
think
children,
so.
so I believe you if you said it.
Yeah.
But the Abilify, I like. In that group of all the neuroleptic medications, some of them can have more of a strong effect versus others. But Abilify, I feel like more people take it, and they usually just continue to feel more like themselves. I've had some people who get sort of like they get really drowsy on it. That's rare, but the drowsiness was pretty extreme. But I'd say that's like 2 patients over like a career. Most people, they take it and they just feel more like themselves and they feel good.
When I tell patients, I'm like, less than 5% of patients get sedated on Abilify, 95% take it during the day.
Yep.
If
That's
you're
been my
one of the ones that
experience,
gets sedated,
absolutely.
then we can take it before bed.
Yeah, and you take it before bed when you are sedated, and that solved the problem both times.
Yeah.
So
I also like Abilify. It's these partial dopamine agonists.
I think that's why people, because it's not, the older medications, they would block dopamine completely. And I imagine, when you block it, we say block dopamine completely, it's not blocking all the receptors completely, right? But it's the receptors that it does block completely. So it's a stronger effect.
Yeah. And
So these are partially activating the receptor. So they're the receptors that are getting affected. It just sort of decreases the activity a little bit.
exactly.
And I can imagine that probably feels a lot more tolerable. So there's Abilify, and a lot of these newer ones, they tend to have less weight gain. So Abilify and Latuda, I've used Latuda before.
And Latuda's not even that new. It's generic already.
Really?
Yeah.
Good.
Lorazepam. What do you think about like Caplyta, Raylar? Those two. And Rexulti.
Yeah, so those two, I haven't ended up using them just because they're newer, and they're usually more expensive, and then the insurance companies will usually push back, and so it's easier to prescribe something that's not going to get pushed back from.
Yeah, and I prescribe
They
them.
may work,
but I'll tell you, I don't usually have to go to them.
Really?
They are way more expensive. They are way more difficult to get, but I can usually get a patient into remission or do pretty well without having to go to these fancy, really new medications.
Yeah, I think because these ones that are older, Abilify, it's Latuda now, right? And then olanzapine if you're not worried about weight gain. But those ones work really well. If we're talking about borderline, it's always low doses and time limited with a clear get off plan. But with bipolar disorder, it is so severe that you really do want to consider staying on the medication long term. And so though in that situation, the recommendation usually is whatever you use to stabilize the mania, stay on that if you can. If you can stay on that, then try to make a smart decision with respect to the side effects of other medications. But a lot of these medications at higher doses will work to try to diminish a mania. And then in those ones, I've used olanzapine a lot more and lithium.
Warning to anyone taking Latuda: make sure that you are taking it with food, at least 350 calories, or else 80% of the medication is not going to even be working.
Yeah, it absorbs.
So if you're taking Latuda, make sure that you take it with a substantial meal, at least 350 calories.
I've been, in recent years, I've been impressed with Latuda. I've been surprised. It's nice. I'm thinking right now of schizophrenia more than bipolar disorder. But for schizophrenia, when I've seen people clear up, it's really incredible.
It's an excellent medication.
A couple of different differentiators between a couple of different things that do differentiate between borderline and bipolar. One of the things is a classic symptom of of bipolar disorder that you don't see in borderline is anosognosia, which is a fancy old Latin word that means to not know the thing that you're supposed to know, right? So people with bipolar disorder, very classically, when they're manic, most commonly do not think they're manic.
They lack insight.
They lack insight. That's what we call it. So they will tell you if it's someone in your life, you could be like, look, you're ruining your life. You could tell them, they're like, no, I have the best ideas and it's going to work out and I'm going to have the most powerful business in the world. I know I'm going to, go do this great thing. I'm going to change the world. It's always the president, whoever the president is at the time. They're going to name the president, say the president's going to listen to me when I tell him this,
Mm-hmm.
So, but that's, and that's sort of just this sort of lack of knowing is the lack of knowing that you have any issue at all. Because oftentimes people with mania will be in the hospital and they'll be telling you, I don't need to be here, and it's pretty obvious that they do need to be there because their life has fallen apart. But on borderline, on the other hand, they have a chronic sense of something is wrong with me, they have a sense that there is something wrong. And they oftentimes, I've had a lot of patients come asking me, what is wrong with me? I just want to know what's wrong with me. That's where I want to start. I feel like things keep falling apart. What is the act? They don't know what's wrong, but they know that something is wrong. Whereas, like I say, mania, they don't even think anything's wrong at all. So that's a pretty clear differentiating factor that you'll see, I think, fairly commonly.
Fascinating. Anosognosia, how do you say that?
I don't know. I don't speak Latin. Anosognosia, I think, though. ANOSOGNOSIA.
Mm-hmm. Yeah. Fascinating.
Yeah. Anosognosia. I'm pretty sure GNOS means like to know or something in Latin. So that's one thing I wanted to say. And then another thing that I wanted to say is when you look at the data, one of the most differentiating factors for borderline compared to bipolar is identity disturbance. So especially when people with bipolar disorder are in between episodes, they will be basically at their baseline. And so they really will look very different, compared to when they're having either a depressive or a manic episode. But people, and they won't have major issues with their sense of self, they will have a better sense of who they are and what they want. And it'll be easier for them to tap in to be like, well, did I want this or did I not want this? They'll be able to answer that question more clearly. And if you can't answer that question as clearly, then you're more likely going to be on the borderline spectrum, because people on the borderline spectrum are usually so busy trying to present some sort of an identity that's acceptable to the world that they end up forgetting to check in and see, what do I actually want? And so then they don't have as much of a sense of self. So they call that identity diffusion or identity disturbance. And that's not as common in bipolar disorder. So that's another thing that's a pretty good differentiator. And then the last thing is just the chronology, because you will see if you read the DSM, it even has this right in there for bipolar type 2. It says that the change between not having an episode and having an episode should be so severe that other people in your life will be like, man, something seems up and you are not.
The mailman will know there's something going on.
Exactly. They'll be like, something is weird and you're not at your baseline, right? But people who are suffering from borderline, the people in their lives would be like, no, actually, that's how they usually are. They, every like twice a week, there's like a breakdown of some sort, and there's some dramatic thing that we have to manage, So people in your life will usually, they'll be like, nah, this is the baseline, and so that's kind of another one that's a good differentiator, that the chronology is totally different, and that there are very distinct episodes, and there should be marked periods of remittance. What I mean is, for people with bipolar disorder, there should be times where they're not having an episode. Whereas with people who are borderline, they have chronic emptiness and chronic worries of abandonment and chronic issues with relationships. And they will vacillate from very high to very low, but very rapidly over the course of hours to days, And people with mania, a manic episode should last at least a week. But I feel like that's rare that it's that short.
Yeah, agreed.
Like I'm working to break a mania. Sometimes it can take a few weeks.
Absolutely. Now, if anybody has any other questions about borderline personality disorder or bipolar disorder or anything else you want us to talk about, if you want to bring Dr. Kanell back, let us know in the comments. And Dr. Kanell, how can patients find you if they want to establish care with you?
My website is eospsychiatry.com. That's EOS psychiatry, all one word, .com. They can find me there.
Thank you very much. This has been another episode of Real Mental Health with Dr. Mike Mah. Dr. Michael Kanell will link his website down below. Thank you very much, everybody.
Thank you. Glad to be here.